What if one doctor's visit could save your life? Too many men wait until something feels wrong before they get checked. But prostate cancer and other serious diseases often show with no early symptoms. So we're kicking off Men's Health Month with a episode every week. And this week I'm really honored to have Dr. Adrian Douglass explaining the importance of annual physicals and how early detection rather can save and transform lives. I'm Reggie Hicks, and this is If You Are My Brothers, and we'll be back right after this. Welcome back to If You Are My Brothers, the podcast. We want to welcome everyone watching on Facebook and YouTube and LinkedIn, and of course, everyone listening on your very favorite podcast platforms, wherever that may be. We ask you to remember to like, share, subscribe, and also engage with us by going to our website at ifyouaremybrothers.org. You can leave us a voice message. You can leave us an email, however you'd like to reach out to us so we can get back with you as well. This is a community. This is a family. So we definitely want to hear from you. Now, this is our first episode in our 4-part series doing Men's Health Month. And we begin our series with primary care physician, Dr. Adrian Douglass. Now, Dr. Douglass is a board-certified internal medicine physician with over 30 years of experience in preventive and primary care. He is an MD-VIP affiliated primary care physician, and he's widely respected for his patient-centered approach to wellness, early detection, and chronic disease prevention. Dr. Douglass is a fellow of the American College of Physicians and has been recognized as one of Atlanta's top docs. And I'm here to say that he is my top doc, literally, because he is my primary care physician, just being fully transparent. And Doc, I really appreciate you keeping me healthy and guiding me in my health journey. And thanks for being here, because I know your day is long and you got a lot going on.
Reggie, thank you so much for asking me to take part in this most important program that we're about to embark on. We're in the middle of a crisis right now as it relates to health, particularly in men of African descent, but men in general. As it is, there tends to be this tendency to put health on the back burner.
Mm-hmm.
There's an element of, being masculine or macho, but too often that gets in the way of men coming in to be seen by myself as a primary care provider, internal medicine specialist, or any other doctor at all. And a lot of times that time is precious, and a lot of times that time can be, if you will, very much, fatal in some situations. So again, if by this evening you and I can talk about, coming in and being seen and having a relationship with a primary care doctor, primary care provider. It doesn't necessarily have to be a physician in this day and time. We have advanced practice providers, nurse practitioners, PAs, someone to kind of help guide and navigate one through this period of time that we're going through right now as it relates to health, particularly here in the 2026 year.
Yeah, absolutely. Just starting with the basics, then, why is it important to have a primary care physician? This is a multi-layered question. And let's talk about the primary care physician as it pertains to the annual physical. And with that being said, what should men expect during that visit?
Well, as it is with having a primary care physician and having a medical home, you want to establish a medical home, a place where someone can come and have all of their care provided and have all their medical information stored, a place where they can reference and the person or the persons there can collaborate on their behalf, advocate on their behalf in terms of their health and wellness. It's important to establish that person early on. Too often, men, as a rule, don't come into doctors until something that's about to happen or something
Right.
that's done happen, and and it's happened maybe more than once by that time, and they finally get gently nudged and sometimes shoved in by their significant others. Uh, so, establishing on your own at the earliest age possible. A lot of men tend to get out of their 20s and get into their 40s before they come in to see a doctor. I would recommend and submit that it's probably wise to start some type of relationship with a primary care provider in your 20s and no later than your 30s. By the time you and I get to our 40s, Reg, and at that point we're on the advent of, in some situations, the beginning of chronic illnesses.
Yep.
So I would say that it's so important to establish that relationship early on. So the issue of the physical exam, that gives you a chance on an annual basis to come in and to first and foremost to forge a relationship with your provider,
Mm-hmm.
physician provider, to establish a rapport, to establish a trust, to know the individual, and to also on an annual basis kind of go over what the plan of care is. It's important to establish that to get some type of benchmarks and begin, the process of repeating and trending and things along that line. So I think it's really important. I say that one should do that, and one should do that early on. Our female counterparts, they establish a relationship with their providers a lot earlier because of just the physiology.
Mm-hmm.
They a lot of times start relationships and have that regularity in terms of annual exam with the GYN doctor. But again, a lot of times men are a little bit late coming to the game.
So you've spent decades in internal medicine. Have you seen any changes in the way men approach their health over the years? Are we still just stubborn knuckleheads?
I'm gonna smile first, and then I'm gonna speak. So there's always going to be a stubbornness to a certain degree to men. That's kind of the testosterone amongst us. So, but I do think that in this day and time of information, which we've been in for the last 3 or 4 decades, I would say, probably since '89, the advent of the internet era,
Mm-hmm.
I have noticed that a number of my male patients come in well informed. But also in the same way, I would say that a number of my male patients come in misinformed or with misinformation that they have gotten from off of the internet.
Mm-hmm.
I mean, the internet is good, but a lot of times you have to kind of, just like anything, you want to check your sources. You want to bounce it off someone, and it's important to come in and to talk and have a relationship with a primary care provider, your physician, whoever that may be, to talk and bounce these things off. There's so much stuff out, and we saw it so much during the great pandemic. All of this that was put out, information coming from the left, information coming from the right.
Mm-hmm.
So it's important to come in and to establish, a regular relationship with the primary care provider. And again, I would say that I think that as a rule, male patients are coming in more informed. But again, I have to kind of watch out for some of the misinformation that's out there.
Do you think that with the internet too, that some men can go and research, and there's always a litany of what it could be, and do you think this is having an effect on men, like taking the lesser issue, or saying, okay, well, it's just a headache, as opposed to it might be a stroke? Or do you think we're being scared into coming in? So I guess my question is, are we using it as an excuse not to come in? Have you found out that maybe somebody's finally come into you because they've been reading something on the internet and it was like, oh, I thought it wasn't any big deal?
I see that, a little bit too often. I mean, the whole idea is that the healthcare provider, myself, physician, PAs, nurse practitioners, we've been trained to kind of put those dots together. A lot of times there is a lot of truth to it, but again, we put it together with the full picture. We're educated in history taking, to
Mm-hmm.
kind of nuance, pull things out of your history that a lot of times too often patients say, well, that's right, I didn't think about that. If you just kind of go with what's kind of given to you from your searches, then you don't necessarily put yourself into it or your particular circumstance. They don't know you. They don't know your story. They don't know your family. Those are so important.
Right.
And you get that when you come in for your physical exam. We establish, the history, your personal history. We establish the history of your family. Genetics is so important. And so I would say, yes, we have to make sure that we just don't do a search. Nowadays, we just can't just listen to AI. We've
Right.
got to have someone that has been trained to kind of think through. And so, yeah, I think that too often people use, and then you can pick and choose with the differential diagnosis.
Mm-hmm.
Now, as an internist, I've been trained to think the worst and work down.
Gotcha.
Prove to me that's not the very worst one at the top, and then work down. Laypersons may say, I want to go for the one that's at the bottom.
Right.
That's the easiest one.
Yeah.
I
Less
can't
scary
conceive
one
it.
too.
Yeah, I
Yeah.
can't conceive it's the one at the top there. I'm going to go for this one, the low hanging fruit. I'm not going to go for the one that's more serious. So, yes.
And speaking of that, have you what major health conditions do you often discover? Now I know I'm not saying that on the first um physical, but over time, because like you said, you're collecting information. And I know for me, with prostate cancer, it was about monitoring the PSA, and we're going to talk a little bit about that in a few minutes. Um, but what have you seen? Someone coming in, particularly men, that have elevated cholesterol or blood pressure and those kind of things, or something that maybe you know didn't show, but over time you're like, oh, okay, this is like turning into something major.
Well, the whole idea is to benchmark and establish with office visit physical examination, and then to examine and to document and to compare. Compare notes to myself, compare notes to my subspecialist colleagues, to compare, to look for differences. Is this correlate, or is there some variance here
Mm-hmm.
of some sorts that requires coming in?
Mm-hmm.
So it requires, as we say in the church, come in and let the doctor or the provider put hands on you.
Right.
Too
Right.
often, that's
Right.
necessary. Touch is therapeutic, but also it puts a bond between the patient and the physician. I'm a physician. I'm going to keep using physician as my primary way of speaking. But it's important. But also, the sense of touch. You know, we are trained in our years of experience, and certainly during our early informative years
Mm-hmm.
of physical examination, to be able to tell a difference, to palpate, to examine, to listen. So I think, on examination, what might I hear? I might hear a difference in the breath sound from one side to the other. I may hear a heart murmur. I may hear a heart sound. I may hear the heart beating too fast.
Mm-hmm.
I may hear no bowel sounds at all. I
Hmm.
may hear some wheezing on one side and not hear it on the other side. I may examine and say, well, did you know that, you've got a difference in one of your organs versus the other side?
Mm-hmm.
There can be a difference in an ear, or the foot may be larger. You can't do that, without, coming in and being seen. So as you and I right now, we're meeting in through, our podcast,
Mm-hmm.
and we have entered into a time of telemedicine.
Yes.
Telemedicine is okay, Reg. It's okay, but you still need to at some point come in and sit across from your doctor,
Mm-hmm.
eyeball to eyeball, to look at your body language, to look at how you change your breathing. When I asked that question, did you shift in the chair when I said something to you? I
Mm-hmm.
mean, those are things that
Ah.
comes from an examination. And again, and then finally being able to put hands on and be detecting and looking back to see what someone else has written and to say, that's not what I see now. There's something different here. We need to look further into this.
And I think the other thing too is that we have to be honest with you when we come in with our doc. I think there's a tendency when asked a question about, does this hurt or have you been feeling this way? Or when we fill out the survey, I think a lot of times the paperwork for us is just, let me just get this done. Let me get it signed. So, because this is the way I get to see the doc. But it's important though, isn't it, to fill out the paperwork accurately and also to be honest about the questions that you're asking.
Yeah, that's important, the transparency. Again, the therapeutic relationship is be pretty much dependent upon just being able to be transparent and clear and truthful with one and another. Both sides, Reg. It's important. That brings the bond between the patient and the physician. And so also it just kind of gives us, a lot of times it is cathartic for the patient to be able to be truthful.
Right.
To come in a room that's closed in and know it's just me and my doc. I can sound this out. I can hear this. It's maybe the first time I've been thinking it, but I'm saying it in a safe environment. So, yes, you have to lay it all on the table. You have to talk. You have to be truthful. And so, again, and you have to feel comfortable with that. That's where coming in, establishing a relationship with a primary care provider, physician, PA, nurse practitioner, and being completely transparent is so important.
Now, seeing a patient over and over again, can you tell, like, when the patient's like, when you say to yourself, I don't think this person, I don't think he's really giving me the whole deal.
Yeah, well, I mean, it's just like, after a while, it's just like, just friends, relationships, children, come in and don't look you in the eye, go off to the side, walk over in this room over here. What's
Right.
up with you? That type of situation, it's just, you can tell.
Right.
You tell. You come in, like I said, body language, hands crossed like this. That's not usual.
Right.
What's the backstory?
Right.
You can tell me. What we're talking about doesn't correlate with what your body is relaying to me.
Right.
So,
Right. So, with that in mind, what we do talk about prostate health on this show. Why should prostate cancer? I think that's an easy question, right? Be a part of your annual physical conversation for men.
well, prostate cancer is, behind skin cancer is the largest, most, prevalent cancer in American men. So it's there, and usually lifetime risk of about 13% in American men will have prostate cancer over their lifetime. 1 out of 8. So we've got to be asking the questions about it. We need to be checking, the examination, PSA, digital rectal exam, i.e. DRE. We have to be doing those things. We have to find out one's history. What about your uncle? What about your granddad? How's your brother doing? Those type of things, So it's just so important because it's so very prevalent in America, but particularly prevalent in men of African descent in our community.
Right.
So it's really important to make sure that one comes in and as a part of, a physical examination, some situations that might not be able office encounter. We're talking men's health, and we just need to do, a brief encounter, and that can entail, urination, erectile function, things along that line, and, family history of prostate cancer, PSA, digital rectal examination. But we got to get there. We got to talk about it because it's one where the outcomes, Rich, are, if caught early, one can survive, one can take care, one can be cured. Generally, defined as 5 years with no evidence of cancer, can be cured. So, very important.
So when someone comes in, what misconceptions do you commonly hear? I know some men are just, not wanting to deal with the prostate at all. I doubt. And do you have men to come in and say, well, doc, I want to know more. I need to, this PSA thing. I got some things going on in my family history. I just found out. Or is it still kind of a standoffish sort of, you have to bring it up? And when you do you find that there are some misconceptions that men might have when it comes to their prostate?
Yeah, there certainly is a lot of misconceptions. Some, kind of satirizing and just kind of vilifying the whole idea of prostate examination,
Mm-hmm.
specifically the DRE.
Mm-hmm.
So, in some situations, in some studies have suggested that you can just get by with just a PSA. I beg to differ. At least as long as I'm going to be practicing, and one can be expected that I'm going to do a digital rectal examination. I'm not going to be just a PSA doctor,
Right.
and so that part of it, you know, the if you will, the magnification of the invasiveness of the digital rectal examination. It's a physical examination. Now, Reg, if someone has an oral abnormality, if I'm really going to examine them, I need to put on my gloves and then stick my finger in their mouth and feel around.
Right.
I'm
Yeah.
checking for oral cancer. It's the same concept. But again, it's been too often the butt of jokes, on Saturday morning in the barbershop,
Yeah.
guys, joking, fraternity brothers, guys on the corner, guys in general, anywhere when it comes
Mm-hmm.
up,
Mm-hmm.
they start to kind of sometimes get back like we're in the sixth grade, joking, laughing
Right.
in
Right.
the eighth grade or something, whenever we were giggling back in them days, just kind of like, but this is so serious, man. It's serious when you have that diagnosis. It's serious, when therapies work. It's
Mm-hmm.
serious when it doesn't work. And so a lot of times the beginning part of it is to come establish a relationship with your doctor or primary care provider, get your PSA measured on an annual basis. Sometimes we check it more than annually based on what's going on with you,
Mm-hmm.
and then get your digital rectal examination performed. So the benefits of the digital rectal exam is, besides us checking your prostate, we also get a chance to check the function of one's rectum, and we get the chance to check for any rectal masses. Now, why is that important, Reg? Because there's someone that on a digital rectal examination, their prostate was normal,
Mm-hmm.
but their rectal tone was abnormal. And what we said is we need to check your spine. And we found that there was something wrong with their spine. That can be,
Oh, wow.
a neurological problem, or it can be a tumor on their spine. Wouldn't have found it if we didn't do the digital rectal, or maybe it would have been later when we found it. Another example, prostate's normal, but what's that off to the right? That shouldn't be there. I shouldn't feel that.
Hmm.
Colorectal doctor, go look, rectal mass. Digital rectal examination, it may have picked it up a little bit sooner before
Mm-hmm.
it starts to give symptoms.
Mm-hmm.
Prostate cancer a lot of times didn't give you any symptoms. It's just kind of cruising along.
Right.
And so, yeah, so again, the exam, when we do it, the creator has given us a prostate that should be, normal size and symmetrical, right down the middle.
Mm-hmm.
In anatomy class, in terms of what we were taught, and too often we saw with the cadavers that we were trained on, right down the middle. Everything should be the same on the right as the left. And so when we see differences on exam, one side bigger than the other, one side, tender and the other's not, one side has a lump and the other one doesn't,
Right.
that's an alarm, regardless of what that PSA says. That's an alarm. Still need to go look a little bit further.
You know,
So,
yeah, that's interesting that this is the first time that I think I've heard, because when we think of the DRE, we think so much of the prostate, that it's also an examination of other things in the area. Because it's not a prostate exam as much as it is a digital rectal exam.
Here's your rectal
Um,
exam.
and so that's great to know. And do you use that to kind of talk men off the cliff? Because I know, I've experienced that being kind of the last thing you do.
Yes, yes, yep,
and
yep, yep, yep.
and how do you deal with someone and I know you don't force anybody, obviously, but have you had to talk some
Well,
guys like off the ledge and say, man, let me do this for the very reasons that you just mentioned?
yeah. Well, I mean, so you and I are in a therapeutic relationship.
Mm-hmm.
I'm on the board. You're the CEO. Now I have to put together a presentation to you that is palatable enough and knowledgeable enough and impactful enough for you to make this decision in terms of how this is going to go.
Mm-hmm.
This
Right.
is not a project.
Right.
In terms of one big company. This is the project of life, your health and wellness. So I have to give you a compelling argument of why we need to go through this. I have to kind of dispel all the myths and rumors, the innuendo, all
Mm-hmm.
that.
Mm-hmm.
A lot of times, my patients, I haven't had a lot over my career,
Mm-hmm.
a lot. Most patients, male patients, they allow me to go ahead and do it. Every
Right.
now and then, I've had to kind of, negotiate, and so
Right.
there has been an occasion where we will get the PSA now. All right, now if the PSA is not right, then then that says, hey, I'm
Need to
gonna
do
need to go
right.
come back. We got to do this now,
Right.
and it's just like in terms of getting on colorectal, long same line, and it gets into just kind of examination of that part of our body, Reg. Uh, I'm not going to do a colonoscopy.
Mm-hmm.
Well, will you take these stool cards? All right,
Mm-hmm.
stool cards can have blood on them, Reg.
Mm-hmm.
Well, okay, we can't do it, but now you have compelling information and an abnormal sign for me to say, now you need to go and do this colonoscopy now.
Right.
That's not going to get it. Now, we found that there's blood in your stool.
Right.
One still makes the decision. And usually that's enough to kind of, if you will, to influence patient to move in the right direction as it is,
Mm-hmm.
for their whole health and wellness. So,
Mm-hmm. Yeah, I will just say this, that I remember back when I had my PSA was creeping up just a little, and we both know Dr. Fowler, who retired, and he was my primary care physician at the time. And I remember him, and I tell this story, that when he did my DRE, he said to me that it didn't feel the way it's felt in the past.
yes.
And I thought that was like, I'm like, how many of these does he feel? How does he know? But he knows me. We have a relationship, and he actually felt that, knew that something wasn't quite right. Even with my PSA was low at the time. It was creeping up, but it was still, under 2. And because it was creeping up and because of what he felt, I ended up going to the urologist and then was diagnosed. So I was diagnosed very early on, but I still think back to that particular exam and what he was able to feel, which kind of led to kind of elevate, what we did next. And that's why, and I tell men all the time, it's so important to go through it and to do it. But I think even more so what you just said is that it's not just about the prostate. It's a lot of other things going on around there that can be serious, can be abnormal, and we need to move on. Um, Let me ask you this. What age should men begin discussing their prostate screening, with you, and particularly black men in particular? Is there an age that that we should say, hey, I know you're getting the blood work and everything and doing it, but really be paying attention to what's going on?
40 absolutely is, absolutely the year at the 40th year, we need to start talking if we haven't already. I'm going to say it for globally for everyone.
Mm-hmm.
So as we talked about the high, incidence and prevalence of prostate cancer in men of African descent. So the recommendations are to start at 40. Not as prevalent in other communities, European, Asian, Latin American, maybe somewhat, but not as notable as in African Americans. So around the age of 40, and I use that. I kind of joke, quote unquote, the boys. It's like 40, and you're entering the middle age now, man.
Right. Right.
It's on. If you're 40 now, come on now.
Yeah.
You're middle age. You're in the middle age. You're in between generally your kids and your parents. And the other thing, importantly, is that a lot of illnesses, chronic illnesses, both the cardiovascular components and the malignant components, begin, to trend upward beginning in the 40s. And so that's the age definitely when we begin the conversations about prostate health, and definitely, that's the time when I start to measure PSAs on my patients in general. Now, if you have a family history, and that's the piece of sitting down and talking, telling people what's going on. As a rule, in most cancer screening recommendations, if you have a family history, then we screen 10 years sooner than the date of the age of the cancer in the family member. So let's say, father had prostate cancer at 41, then the conversation starts at 31 for the son, or, the little brother or something like that.
Right.
Because this family member has prostate cancer. And so we want to start, and got diagnosed at 41, didn't start at 41. It probably had started to grow, as you know, Reg, 38, 37. So we need to start in that situation for the next family member to 10 years early. We need to be looking at, what's going on. And so again, that can be, if nothing else, PSA, DRE, a little bit more of a robust conversation, getting the DRE with a 30-year-old, as you can imagine, Reggie, as as compared to a 45 and 50-year-old man.
Right.
I've really got to come out with my lobbying techniques, 30-year-old. And it has to be a reason, too. And it's usually looking in the back, family history, or something, that's not right with what you told me or what you're telling me, your history. And, prostate cancer can come in a lot of different ways. It can be silent, but it can come with, changes in urine. A lot of times it can come with changes in erection. So it gets into the male conversation in confidence with your doc.
Right.
Being transparent, not being machismo, not being macho, laying it out, what's going on. That's when, a lot of the work, the hard work gets done inside that room with the patient and everything.
So one more question as we kind of transition just to some more general information.
Yes.
Have you experienced someone coming in to see you and they're having symptoms, they've not had a PSA in forever or, a long time, and the PSA is way up there, and unfortunately, it starts to spread? I mean, have you experienced that in your practice?
I have on occasion had people to come to me that, and had a gap in their care for a number of reasons. A number of reasons, change in employment, going through a divorce, just, recovered from some other challenge, if you will, if you know what I mean, behavioral health, emotional health.
Right.
That wasn't the primary thing. In the meantime, they did keep up with their physical, well-being, and didn't have the ability or the mindset or the time to come in and see their doctors to get that, and come in, after a period of time not having been seen with symptoms suspicious and values being abnormal, and in some situations, disease being more than at the earliest stages. And so that's a hard one for me, Reg, because prostate cancer is a cancer that if detected early, and it's well known. I mean, I think it's, we may not be as publicized as breast cancer, and no difficulty with
Hmm.
the women.
Hmm.
October and pink and all like that, but it's known. We we know about prostate cancer, and so when that situation comes, that strikes me real hard. Because in the perfect world, with everything being in place and in synchrony, then and them being tested, then that certainly likely could be picked up earlier and certainly cured. And so,
Yeah, yeah. I know that's a tough one. As a matter of fact, this whole project started with someone, my fraternity brother, who similar, just didn't really go to the doc a lot, or didn't really have physicals, or if he did, the PSA wasn't at the top of the list, which I don't understand. But and he didn't know family history until after he was diagnosed. But when he did find out, his PSA was 100,
mm,
and really had to go through and deal with this really aggressive form of prostate cancer when he was
yes.
diagnosed. And was with us for 6 years. But again, it's when I started learning and when I was diagnosed in doing this project, to really understand, how blessed I was to be diagnosed as early as I was, even with no symptoms, even with a PSA that some would say at my age was more normal than abnormal. And that was because of knowing my numbers and having, that association with my primary care physician, again, that knew my prostate didn't feel right.
Mhm.
So it's so important to establish that relationship. And when you have this annual physical, what other screenings or health indicators are critically important for men to monitor and to ask for?
Yeah. Well, some things we get just with the vital signs.
Hmm.
Blood pressure, obviously, know what that is, and then also our weight and the calculation of our BMI, body mass index, know what that is.
Yeah.
Trending that, comparing it to what it was before, 6 months, 3 months, a year ago, those type of things. One that may not be as well known is really getting an accurate height. Why
Hmm.
would I say that? As you and I get older, then we don't have the testosterone that we used to have. We don't
Right.
have the muscle mass that we used to have. Probably because we didn't have the testosterone. But there are other reasons too, lack of exercise, things along that line. But the same concept that leads us to lose muscle mass can lead us to lose bone mass. So
Mm.
you think about, women, and a lot of the advertisement, direct consumer advertisement for bone medicines, osteoporosis pills, is geared towards women. They don't ever show a dude.
Right. Right.
As a
Yeah.
rule, yeah, as a rule, our testosterone tends to, and our big muscle mass as compared to women, tends to protect us a little bit longer. And really, the screening from the standpoint of bone and osteoporosis in men
Hmm.
should start somewhere around 65 to 70 certainly by that time.
Hmm.
So a change in your height is what I'm getting to. If you come in and you're getting shorter, 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 then one needs to be looking and putting the dots together and looking to see where are you in life. Could there be some type of metabolic problem involving the patient's bones? So that's important also too.
Well,
That's just your vital signs.
yeah, I
Uh,
think my wife is going to be listening to this part, because she did say, I've been 6'1" or 6 feet for as long as I can remember, and she looked at me. She says, "You're 5'11" now," and I'm like, "No, no, I can't." So,
yeah.
but I
So all of us.
but I
So
am
all of us.
at
Yeah,
five
yeah, yeah.
eleven. Yeah.
And so yeah, and so as you made reference to a fraternity brother, I know for sure, a fraternity brother of mine that was behind me in terms of when I
Yeah.
witnessed him joining, pledging, and he was number one on his line.
Hmm.
And I can remember when him being lined up, I was taller than he is. I'm
Right.
not taller than him now. So anyway, we move down, and so checking bone density in us as we get older, and sometimes, a part of the physical examination is seeing the trend of your height is a key that at some point we may want to take a look at that. So
Interesting.
just, food for thought.
Yeah.
Other things, you get your pulse oximeter. That's where you stick your finger in. and it tells you what your oxygen level is. That became really well known during the Great Pandemic.
Mm-hmm.
Everybody wanted to get a pulse ox to know what was going on.
Right.
And and that's still important information. It's kind of you can look at it, and it also gives you your heart rate. And so without having one of these heart monitors, which you can get directly, by the way, you can look at your pulse ox, and if you see a change in your saturation, any of the numbers, if they start to be variable, then that's not normal. Once you put the thing on your finger, the number should stay close to where it is. There should not be any type of bongo drum change in variation. Yeah. That can mean that there's something going on with your heart, but it can mean something going on with your oxygen, or it can mean a little bit of both. So that's kind of when you walk in the door, the type of stuff that we do. But other things, you talked about know your numbers. Another number, know your number, is your A1C. So A1C is your hemoglobin test, and what it does is hemoglobin A1C, and it is a measurement of the amount of glucose that's been absorbed in the cell membrane, your red blood cell membrane, and that tells us, kind of what your average blood sugar has been for 2 months. And that's based on the fact that red blood cells live for about 2 months. And so knowing that, we are in a time of prediabetes and diabetes.
Yes.
And a lot of that, has to do with over the last 30 to 40 years, as a rule, Americans have gained weight. So our BMIs have gone up. And so that's important, knowing what that is. Knowing what your LDL cholesterol is, that's your bad one, and so knowing what your cholesterol numbers are, that's important. So those are the main ones. If you want to kind of know, we're looking at LDL as kind of the gateway to cardiovascular disease. And then, A1C is a metabolic test, in terms of prediabetes, diabetes. PSA obviously is a testing from the standpoint of prostate cancer risk. PSA sometimes can be elevated for more than just cancer. It can be a big prostate. It can be a urinary tract infection, a prostate infection. It can be a recent heavy workout on an exercise bicycle. In other words, sitting on a bike doing spin class for too long. Right. It can be recent sexual activity too. So knowing that also is important, what your PSA is. But there can be some benign variations in a PSA.
And what about, and I'm going to get you to talk about this because you showed me this diagram because I have sleep apnea. I have a CPAP machine, so I wrestle with that every night, but I'm using it. But you showed me this graph of how sleep affects just about everything, and how sleep apnea can affect everything just about in your body. It's amazing to me.
So we need you need nutrients, you need oxygen, and you certainly need your glucose and all the nutrients that you need throughout your body. So from the standpoint of oxygen, when you have sleep apnea, your body slows down. Once you go to sleep, you slow down, which everything powers down, just like the computer. When you finish, this is going to power down. You power down, but some of us, we power down so much that we stop breathing. So that's not good, as you can imagine.
Right.
I used to swim very well when I was younger, and I could swim the length of the pool on one breath. So that's the concept of it. Instead of swimming the length of the pool on one breath, now, when you have sleep apnea, you're coming up for air often, except that you don't know it. And that's detrimental, as you can imagine. Your brain's not getting oxygen, your heart's not getting oxygen, your pancreas is not getting oxygen. All these organs are not getting oxygen. And so that causes problem. It causes your adrenal glands to secrete adrenaline. It's warning. It's hitting the pots on the pans. Right. It's an alarm. Something's going on. Just rev up the blood pressure. Make the heart race fast. It can make your heart beat irregular. A lot of people have atrial fibrillation associated with sleep apnea. And so, and it can cause acid reflux.
Wow.
Food coming up out of your stomach. It can affect your testosterone. We talked about hormone secretion, but not having enough oxygen to your brain and pituitary gland can affect your ability for the signal to be sent for you to produce testosterone. So therefore, we start to have lower testosterone levels. And again, that means less muscle mass, more body fat. More
Wow.
body fat
Right.
is going to be more likely to lead to prediabetes. So just it starts to cascade downward.
Yeah.
So it's important to get a good sense of sleep. Whatever that may be, in terms of timing, is somewhere between. We would love for you to get 8 hours, but at least a minimum of 6 hours. But ideally, 8 hours of sleep a night. And anything that affects your sleep, can affect, all the other things that we talked about. As a rule, unfortunately, people that are night shift workers, their health and wellness tends not to be as good as people that are day shift workers.
Right.
The circadian rhythm is off.
Right.
And so that becomes a challenge and things along that line. So,
well, I will say that diagram you showed me, I was like, okay, I'm getting sleep study. I'm getting my CPAP.
yep.
I'm doing this thing because it is so connected. Doc, as we kind of close out here, we talked about some of the things that men should be thinking about, like particularly going into the annual physical. First of all, getting an annual physical. But I also am a realist in that, fortunately for me, being a part of MD VIP, you spend a lot of time with me in my physical. But
Yes.
the reality is that could be, before MD VIP, my physical with the doc might have been 15 to 20 minutes. So knowing that that's kind of the average, and I'm going in, I want to know my A1C, I want to know my PSA, I want to know my cholesterol. What else should I have? What kind of checklist, if you will, should I have ready to do my part before I go in to see the doc for my annual physical?
Well, you want to also know your kidney function and your liver test. So this idea of glucose or rather a glomerular filtration rate, that's the amount of urine that your kidney produces. There is also, Reg, an epidemic of chronic kidney disease, usually based on the underlying illnesses of diabetes or prediabetes, hypertension, or prehypertension. It can also be associated with urological problems. In order to the urine to come out of the kidneys, where does it have to go through? It has to go through your bladder and your prostate. So you get into obstruction. Structural problems involving the urinary tract system can lead to that also. So one wants to make sure that the labs reflect a kidney function. To get the full sense of the kidney function, you want to have a creatinine measure, which is a blood measurement. That's the fuel, that's the blood that goes into the kidney, but you also want to get the exhaust. That means you want to get a urine examination. And what are we doing looking through urine? Where we're looking to see if there's glucose in there. That may say to someone that's at prediabetes or diabetes. We're looking to see if there's blood in there. That gets back into, as you know, Reg, urological malignancies,
Right.
Bladder cancer, prostate cancer, kidney cancer. Shouldn't have blood in your urine. It can sometimes suggest that there is a problem from the standpoint of an autoimmune condition, such as lupus or sarcoid, things along that line. We're looking for protein. Protein in your urine shouldn't be there. That's usually an alarm that something's not right, either with the kidney itself or the interstate system, the vascular system going to your kidney. Okay. Something somewhere amongst that system throughout your body.
Something is off.
For you to have protein in your urine. It's not supposed to be there. So at least we're looking at the kidney, but if it's not clear that it's a primary kidney problem, then we need to look through the cardiovascular system. Sometimes that can be a sign of a storm coming from the west, that there may be and a stroke coming or a heart event coming by the protein that's seen in your urine. And they've started to do a lot of direct consumer advertisements about urine tests for protein. I've started to notice those, and I appreciate that. And then your liver enzymes. Your liver is, and I'm using terms to kind of help it stick. Your liver is your filter. We love our rides, we love our cars, so that's your oil filter and your air filter. You know how that looks. So you need to know what your numbers are. What is my liver enzymes? Are they up? Elevated liver enzymes can mean that there's something primarily going on with the liver, or something that is coming from somewhere else, getting caught in the liver.
Mm.
And again, we have also this epidemic of liver disease called fatty liver disease that again comes in conjunction with what we call the cardiometabolic syndrome. Starting to put it all together, Reg.
Mm-hmm.
Sleep apnea, diabetes, prediabetes, hypertension, cholesterol is not right, if you will. Liver has extra fat in it. Kidneys are not working. All of that can be related and intertwined and seen with those tests that we talked about. And again, cardiometabolic syndrome is just it. It's a metabolic syndrome that leads to cardiovascular events, strokes, heart attacks, risk, and things along that line. So those are things that you want to make sure. And that's usually gotten with, a urine test and a simple blood test.
Right.
Comprehensive metabolic panel, that tells us that. A1C tells us prediabetes, diabetes. And then there are other ones also. We need to know what our blood counts are. You don't want to have low blood.
Mm-hmm.
That means something's going on.
Mm-hmm.
Anemia, in other words. You don't want to have that. And there are many, many other things. But, as we kind of come to an end, I think those are the ones that you want to kind of be clear about.
Right, right. And one of the things I do too is kind of go through and just do a check of me, arms hurting, my hands got some issues, because my back's not, so kind of do your own inventory to make sure that, and I write my stuff down, as you know, and I have my little book and check it off, because if you don't have a lot of time, it is important to address those things that are happening to you now. And I think the blood work and the urine analysis and those things. So go in with that mindset of this is for me, and I know I don't have much time, because like I said, most often you don't, then to have that checklist available to get through, so you can come out kind of with peace of mind and knowing what you may have to do later, or you may have some additional tests. Mm-hmm. So and I will say this, Doc, that diet and exercise is so important. We won't get into that because we're going to be getting into that all month long. But I know we talk about that in our exam. You also give me so much information on my, being pre-diabetic, what I should be eating, what I should be doing. So I just want to thank you for that. I just want to let people know we're not excluding that, but we just want to make sure we get this part of it, knowing that we're going to also address that in future episodes this month. Final question.
Yes, sir.
So imagine a 40-year-old man listening right now. He's busy, he feels fine, but he hasn't had a physical in like 3 or 4 years. What's your message to him?
I would tell them that they certainly want to carve out time from their job to come in and establish with their primary care provider, be it physician, nurse practitioner, PA. Take the time, to allocate the time to go in and get a physical examination. Sometimes you want to kind of start off with just an onboarding visit. Sometimes we do some simple labs and urine, things like that, but follow up with the physical, because that's comprehensive. That's looking at your lifestyle and your behaviors to prevent chronic illness. We're trying to catch up and make sure your immunizations are up to date. We're just trying to catch things early, and we're trying to get a good medical history. Remember, our presence is here because of our family members, ancestors before, and they have a story. We have to continue to tell this story. And so being able to sit down and give your healthcare provider, physician, a good history of what's going on. So in addition to knowing your numbers, Reg, in terms of what we talked about, PSA specifically tonight, A1C, LDL, cholesterol, you want to know your family history. You want to know your story. You want to know the Douglass story, if you will, Hicks story. You want to know that. Bring that, have that ready and prepared to talk in terms of about that with your provider and everything. So that's the thing that I would tell you. Excuse me.
Okay.
Yep.
Great, great, great. Well, we're gonna let you get that call because it could be a patient. But I just want to thank you, Doc. We're gonna have you come back on. There's so many other things I know we could be talking about, need to talk about. But this really is a great start, and
Yeah,
I know that you're really busy. But thank you for all that you do, for the many many patients that you have, for what you do in the community, and thank you for what you do for me. I appreciate you,
you're welcome,
and
Reggie.
thanks for taking the time.
I appreciate it.
All
Pleasure
right.
and
Thank
honor.
you, Dr.
Thank you so
Douglas.
much.
So, brothers, your health is not something to put off until tomorrow. One annual physical, one conversation, one decision to get checked could make all the difference. And my thanks to Dr. Douglas for helping us understand why prevention and early detection matter, especially when it comes to not just prostate health, but your health, your entire health. Um, we want you to schedule your checkup. For if you're watching right now, that's the next thing you need to do. Remember, on this podcast, we always talk about taking health action, health awareness rather, and turning it into health action. It means to do something. So it's important for you, if you haven't had a checkup in years, if you've not like been putting it off and putting it off, go ahead and do it right now. Find you, as Dr. Douglas said, find your primary care physician, internal medicine doctor. Maybe it's a PA or someone that can begin this conversation and begin this process. We want you to take care of yourself, not just for yourself, but also for the people that love and depend on you. So, if this conversation has helped you, we ask you to please share it and subscribe and like, and so you'll be alerted to future episodes. And we've got a number of episodes as we uh, celebrate, if you will, Men's Health Month here in the month of June. Also, you can visit us at IfYouAreMyBrothers.org to learn more about our project, which includes a documentary, courses, podcast series, and the community engagement work that we do. If You Are My Brothers is dedicated to turning prostate cancer awareness, as we mentioned, into health action. It is a project of the nonprofit 501c3 organization Straight Street Media. Now, that being said, you have some support options because we are nonprofit. Thank you, Danny. On the screen, if you're watching on YouTube, also we'll have the links in our show notes as well. And definitely for the podcast, the audio version, you have a number of ways to give, but you can give online at ifyouaremybrothers.org. You can also send us a check. But at the website, you can click on donate and it'll run you through the process. So you can use any of your credit cards or debit cards. So we appreciate that. And when you do make your contribution, you'll get your very own If You Are My Brothers mug. If you see it here, I have it on every episode. We want to thank the folks over at Atlanta Brand Central. By the way, Atlanta Brand Central, if you're looking for any kind of swag that you want to do for maybe a family reunion or maybe a college reunion, a school or birthday, graduation, these are the folks to get in touch with. Their link is in our show notes as well. And special thanks to our producer, Danny Garcia Pozo. Thank you, Danny. He had a little problem with the slide, but we're gonna work on that. And in post, right? And also we want to thank Zach Reynolds at Borkhouse Productions for putting together our opening as always. Remember, this podcast is not a substitute for medical advice. Always discuss that with your healthcare provider. And that being your primary care physician is one of those. So make sure you have that healthcare provider, right? Now, thanks for being a part of our first installment of our Men's Health Month special series. We have additional episodes that will be happening coming this month, so stay tuned for that. And when you do like and subscribe, you'll be notified when the different episodes drop. So until then, we want to remind you that if you are my brothers, you will share this message. As always, we are in this fight together with you. So that being said, we ask that you take care, stay healthy, and keep the faith. Thanks for tuning in. Peace.